Good evening and welcome to the Roselle Center for Healing's ongoing educational series. My name is Dr. Harlan Browning and I will be bringing a presentation tonight about myofascial networks, the missing link in unresolved musculoskeletal pain. We'll be touching on a series of subjects, specifically what I call the Triad of injury. We'll look at the roles of fascia, a concept called the tensegrity model, 4 causes of fascial damage, our systemic response to pain, and ultimately we'll look at 6 steps to pain resolution and healing. I like this slide because it helps you understand what happens when we have injuries. And I break injuries down into 3 subsets. One is acute. An acute injury kind of makes sense. That's the one where we slip and fall or we twist an ankle and we cause an injury pretty quickly. The next one is what I call chronic. And chronic injuries are more or less what we refer to as overuse syndromes. This is where we do something over and over again until the tissues are compromised and eventually start to fail. A good example would be sitting at a desk using a mouse. If we use the mouse and we grab it with one hand over time, then often we will start to develop wrist problems or elbow problems. And the last one I call adaptive. And in the adaptive model, this is the changes that the body takes on over time, and we call that our posture. For some folks, posture is good. For many folks, it's not good. So postural changes over time are adaptive and very often put strain on that fascial system that we're going to talk about. Now, anytime we are referring to an injury, we have to look at a timeline that takes place. And when we look at this model, we see, hold on, I'm going to pull up a laser. At this point, we are at a place called homeostasis, which means that we're fine. Let's say, for example, we're looking at one of those acute injuries where I slip and I twist my ankle. As soon as I twist my ankle, within seconds, the body tries to protect it by laying down what's called platelets. Platelets block the blood supply from spilling out. In other words, if I've injured a blood vessel, then it's going to plug it up so it doesn't spread. Soon after that, it's going to start to lay down fibrin, which is a connective tissue that is there to just protect us early on. And then we start to go into a cascade of inflammation. Inflammation is extremely important for the healing process. For a lot of people, inflammation lasts too long, so the healing process does not go to maturation. So as we go into the inflammatory cascade, our body sends out a series of white blood cells that go in there to start to repair things. And as they repair things, they go into a mode called proliferation. At this point, we start to see the rough cells like fibroblasts and collagen start to be formed, and eventually they get remodeled into good connective tissue. Unfortunately, in some people, we will end up with scar tissue maturation, which means that instead of forming good, healthy, quality tissue, we often will form scar tissue. And that's going to be kind of the basis of some of the concepts that we're looking tonight with this myofascial network. So here is a picture of the fascia. And fascia is connective tissue that plays an important role in almost all human function. It's about 16% of our total body weight, and it stores about 23% of our total water composition. So it's a large part of what we are. It interconnects all the tissues of the human body, including our muscles, our organs, nerves, and vessels. So it's more or less an all-encompassing structure from the outside inwards. And it's extremely dynamic, and it changes based on the stresses placed on it. So the more stress it has to bear, actually the tougher it'll get and the stronger it'll get. The less stress it has to bear, the weaker it will come. This is a kind of up-close view of what connective tissue looks like. And I added this in just so you can get a better understanding of all the things that are involved with it. So if we look at this picture in the background, this light blue, this is what's called the ground substance, and the ground substance is kind of the batter of the connective tissue. And in there we find things called proteoglycans and glycosaminoglycans. These are the things that give us substance, and specifically It's made up of things like hyaluronic acid, glucosamine sulfate, chondroitin sulfate, things of that nature. And we see people take those, and that's the reason behind taking those supplements. It gives us more of that ground substance. It gives us basis. Within this whole ground substance is a lot of other tissues. We see that there's nerves in here, the yellow. We see that there's collagen fibers. We see that there's elastic fibers. Okay. We see there's blood vessels, and we also see that there are white blood cells. So we have lots of things within here. Additionally, we see that there's fat cells, and these are quite important because what happens over time as this connective tissue becomes weaker or as it becomes damaged, we often see that these fat cells infiltrate it and become more prominent. We'll see a slide later that shows a pretty good illustration of that. And lastly, I want you to just look here. This is called a fibroblast. The fibroblast is what makes the collagen fibers. So as you can see, this fibroblast is going along this collagen fiber, and it's making it, and it's actually healing it and weaving it together. So in this conglomerate is what we see if we looked underneath of a microscope, and it certainly causes us to have changes in our fascia as we age. So let's look at the layers. Starting from the outside in, here's the first layer of skin, then we have a layer of subcutaneous fat, and then we have some superficial fascia. So it separates a subcutaneous fat from a little bit deeper layer of fat. Underneath of that is a deep layer of fascia, and then ultimately the muscle. The fascia can also go to the outside of the skin, and you can actually see it here. So the fascia starts typically from the outside and goes in, but it's most likely that we're going to find the concentration is just below this fat line. Well, what roles does the fascia play? It plays a major role in the circulation of blood and lymph. And when we looked at that other up close slide of the fascia and the connective tissue, you could see those blood vessels that were within the fascia itself. It's important for the nutrition and metabolism of every cell in the body, and vice versa, because it's a conduit to spread nutrition. The more that we move, the better that we can do that. It's the first line of defense in our immune system. So when we have disruptions in the fascia, then we're going to have changes in the immune function, and ultimately we'll have changes in movement. Fascia is a major contributor of both sensation and proprioception. Proprioception being the ability to tell where we are in space. It works as a matrix of communication between all our cells, organs, and body systems. It provides a tensile support for muscles and is important in generating force. And we'll look at some other slides that show you the importance of the fascia to help us be more efficient and conserve energy. It helps us transfer energy from the ground up, and it maximizes efficiency. And it connects the livable erector set. And let's take a look at that. For the engineers that might be listening to this, there's something called a tensegrity model. And the tensegrity model can be applied to the human body itself. A tensegrity structure is based on the premise that the integrity and continuity of a structure is due to its tensional elements. Wires and other sorts of line connect with each other and sustain continual tension by the hard pieces of the structure. So in this case, the hard pieces of the structure would be the PVC piping, and these wires would be the tensile structures. The compressional elements, which do not touch each other, in this case the PVC piping, act as spacers to maintain the tension. So when we apply it to the human body, and if we think of that, I like to say that the human body is more like a suspension bridge than it is a skyscraper. So when we apply it to this, we can think of the muscle, skin, and especially the connective tissue as the tensional elements within the system. So those are the wires. The body's hard compressional elements, the bones, act as the spacers that sustain the tension. So your bones are the hard elements, the connective tissue is the tensile structure. So stress is distributed evenly throughout the entire structure than rather allowing it to accumulate in certain points. So this configuration allows us to have tension throughout the structure and distribute it evenly, or hopefully evenly, and we'll look later on when that does not take place. This design allows for more stability flexibility, and as opposed to a rigid structure, it gives us the options to be extremely mobile. Well, the marvel of the tensegral structures is they are highly adapted to stress and can therefore support loads without experiencing structural failure. The fascia provides a platform to conserve and transmit stored energy, and within the human organism, one of the most prevalent tensile structures is the collagen. Now, with this picture to the right, I put this in here because I think it's extremely neat to see this. This is a dissection of connective tissue, specifically fascia, from the person's foot all the way up to their tongue. Yes, that's right, from the foot to the tongue. So this person did a dissection and teased out all the fascia to show you how it interdigitates and connects between the point of the foot to the tongue. So from here it goes to the foot, now we're going through the leg, now we're going through the thigh, all the way up. Now we're going into the abdomen, to the diaphragm, all the way up to the tongue. So pretty neat to look at, and really explains a lot about the way our fascia works to help preserve our organ systems. Well, if we look at the fascia, we have to be able to move that fascia, and there's a term that was coined by a therapist named Myers called anatomy trains. And what he said is muscles are oriented in contiguous fashions, and these longitudinal pathways help us to convert the heel strike into energy to give us stability in an upright state, or what we call the gravitational field. So these anatomy trains help pull along the body, and they do it through the connections of the fascia. Dysfunction or trauma along these various anatomy trains is propagated from head to toe, meaning that if we have dysfunction in a muscle group, let's say we've injured a hamstring here where it attaches to our pelvis, we've probably all experienced that where we pull a hamstring, then it's not going to allow us to transfer the energy up through here and across. So this would be unlocking or unhooking the cars of the train. So muscle function parallels fascial function and actually is the driving force. Now, let's talk about 4 causes of the fascial injury. And we're going to break these down and look at them specifically, but I think there's 4 subsets that are pretty applicable to my talking tonight. One is trauma, blunt trauma. We touched on that. That's rolling the ankle. One is repetitive motion, poor mechanics or posture, and being aging or immobile. The 2 typical patterns that we see of deterioration of connective tissue is something called tendinitis or tendinosis and ligament hypertrophy. In the body, tendons connect muscles to bones and ligaments connect bone to bone. And what happens is when they're placed under excessive load, they'll often start to fatigue and they'll be taken beyond their capacity to restore. And as that happens, they'll physically break down. In this picture right here, this is a tendon. Okay, here's a tendon sheath, and you can see all these tendrils. These are smaller, little tiny portions of the tendon. You can see that they're fraying. And as they fray, they're going to start to form inflammation and scar tissue. So this is more or less the tendon starting to break down and become rigid. So tendinosis is the end product of long-standing tendinitis, which is an inflammatory situation. Because the connective tissue in the fascia attaches through the tendons as well as the muscles, this again becomes a component where we unhook those cars. Conversely, over here, we might look at something called ligament hypertrophy. And ligament hypertrophy is where the ligaments, in this case is ligaments of the spine, start to get thicker over time because they're bearing too much of the weight. As they bear more weight, they physically get thicker because we lay down more and more scar tissue or fibrous tissue. As these ligaments get bigger, they take up room, and ultimately we may develop something called spinal stenosis. And this is not an uncommon thing to see, and it usually tells you that the person has had poor mechanics at that joint. And you'll definitely will see it in the spine. Sometimes you can also see it in other joints, but classically we see it in the lower lumbar spine because of people have very poor core integrity and core strength. Cumulative injury is an extremely important issue with the patients that I see in my office. And what happens is they get caught up in this wheel effect where they traumatize tissue. Okay, we might pull that hamstring. We cause inflammation. The inflammation causes us to go into spasm. When we go into spasm and we start to heal, we may lay down adhesions. Adhesions are scar tissue, and I'll show you a slide a little bit later that's a little bit more specific about adhesions. And ultimately what happens is it causes an altered motor control. In other words, the muscle starts to contract and relax differently. It's been changed. Well, this leads to a muscle imbalance. Now we have a weakness in one muscle group in opposition of a muscle group. So this imbalance propagates more tissue trauma, and then this cycle continues. So muscle imbalance from front to back or side to side becomes extremely important as it relates to a cumulative injury cycle. A great example of this is the rotator cuff. The rotator cuff is a small group of muscles in the shoulder that's main responsibility is to keep the shoulder down and back and to keep our arm slightly rotated out. Well, most of the muscles in the front of our body do the opposite. They bring the shoulder up, they bring it forward, and they rotate it forward. These muscles are almost always stronger than the rotator cuff. So what we often will see is as time goes by and these muscles become stronger because we use them more, it comes at the expense of damaging the rotator cuff and having this cyclical change take place. So cumulative injury is a phenomenon that's becoming more and more prevalent as we see people go from heavy workload jobs, construction, things like that, to sitting type activities. So a closer look at that aspect would be this. This is a illustration of something that we call lower crossed syndrome. And this is a postural syndrome that takes place in the low back, and you can have something called upper cross syndrome as well. So standing and seated posture is a reflection of our adaptation to gravity, life experiences, and that tensegrity model. Poor posture is a chronic injury state, and bad posture for the most part is bad health. So in this illustration, okay, and this person may have back pain, or they may have knee pain or hip pain, we see a cross here. This person will develop tightness in their spinal erectors, their back muscles, and they develop too much tightness in their hip flexors because they sit too much. And this comes at the expense of getting weaker abdominal muscles and weaker gluteus muscles. So this cross causes a lot of irritation and stress to the lower part of the body. So this person could have back problems, it could have hip problems, and sometimes even knee problems. This is a common postural pattern, and one that I often will talk to patients about. And this is for this reason we talk to patients about core strengthening and stretching protocols that are essential to having good posture and ultimately good health. Now, this is a really interesting slide that I thought I would put in because it gives you a little bit more understanding of that slide from before that looked at the connective tissue from a microscopic state. So we have two people, young and old. So coming out of the gate, we see that this person who's younger, these are muscle cells. You can just see that they're uniform, they look relatively healthy compared to this older person who has less formed muscle cells. And see this, the yellow, that's the fat infiltrate. Okay, so that's what happens. Over time, the fat will infiltrate the muscle cells. So at this point in time, the person sustains an injury and placed in a cast. Okay, as they're put into a cast, after they take it off, the first thing that you can see is all this yellow. Because we've been immobilized, we start to lay fat in between the cells. And here in this older person, you can see it becomes fairly substantial as far as the accumulation. But after the person starts moving, both young and old, we can see that the muscle cells start to get larger. The fat infiltrate starts to change, it's becoming a little bit whiter. Okay, and in the case of this person, because these cells were damaged, now we're seeing a complete replacement here. So eventually these fat cells will switch back over to a healthier muscle cell. Let's talk about common pathological changes to the myofascia. And we've heard of some of these trigger points for sure, but we also develop things called adhesions, fasciitis, and myositis. Trigger points and adhesions are something that we've all been aware of, specifically trigger points. So a trigger point is a hyper-irritable part of the muscle. There's a knot that starts to form in the muscle, and typically it forms in what we call the belly. That's the center part of the muscle. So here in this muscle group, this is the rhomboid minor group, we can see this X is the location of a trigger point. And what we find is that trigger points not only cause localized pain, but they'll cause referred pain, meaning that when we push on this trigger point, so if I push right here, or I push right where this guy is, we're going to get pain along this distribution. So even though the problem is here, we may perceive it in our finger. So trigger points become one of those things that you really need to consider when a person has unresolved pain in, let's say, their arm or their leg that's being blamed on maybe a compressed nerve or some other thing. Sometimes it's something much more distal than it is something much more local. The second one we look at are what's called adhesions. And adhesions are scar tissue formation that bridges over from one muscle fiber or one connective tissue to the other. The problem with adhesions is they don't allow these filaments or these muscle fibers to move individual of each other. So like we referenced before about the anatomy trains and the ability for us to move structures, and in this case unhooking the cars of that structure, the adhesions will often do that. So when a person develops adhesions after an injury, it's extremely important for those to be addressed and removed if you want good fluidity of that tissue, and certainly you want good quality movement as a whole. In some cases, we get soft tissue inflammation, and the classic one that we talk about is plantar fasciitis. We've all heard of that. Well, fasciitis just means that we're getting inflammation of the fascia. The plantar fascia is a large fascial structure on the bottom of the foot, and it more or less connects the heel bone to all the toes. And unfortunately, because a lot of people wear ill-fitting shoes or they have poor mechanics in their feet, they put an excessive amount of strain throughout the plantar fascia. So as that happens, the plantar fascia will often break down and will become inflamed. If it is inflamed long enough, it can cause irritation to where it attaches here in the heel, and this can lead to things like bone spurs. But for the sake of this conversation, the fasciitis is nothing more than just inflammation of the fascia because, again, we bring it beyond its load capacity. On the flip side, we can have inflammation of the muscle itself, which again is usually deeper than the fascia. And typically we see this myositis from a trauma. It can be also because of too much constriction, too tight of a fascia that surrounds the muscle. Literally, it can choke it. But what happens is as the muscle becomes damaged internally, it will swell. And as it swells, it will often be limited in the amount of movement that it will allow. Now, I want you to see this. This is a transsectional area. So they cut this person's thigh here. And you can see these are muscle groups, okay? Individual muscle groups. Well, what separates them is fascia. So the fascia goes deep. So if we injure this muscle within the leg, then it's going to stretch and it's going to be compromised by the ability for the fascia to stretch, or maybe it doesn't stretch. So myositis is indirectly a fascial problem as well. So again, they're both inflammatory in nature, and they really both involve the fascia. Well, when we're in pain, we start to see a shift in our sympathetic and parasympathetic system. That's what we call our autonomic system. As we move more to sympathetic dominance, we see a change in our production of something called cortisol and adrenaline. It's more of a fight or flight response. As this happens, we have increased sensitivity to pain. We see an increased resting muscle tone, and ultimately we have a decrease in our restorative capacity. So for folks who are in chronic pain, they have a tendency to oscillate somewhere within this sympathetic section, and that comes at the expense of the parasympathetic. So we'll also start to see changes in restorative sleep, digestive capacity, and immune function. So the longer we stay in the sympathetic side, the more that we see the body start to deteriorate. So in reality, when you have a person who's in chronic pain, you have to not only reduce their pain component, but you have to shift them back to a parasympathetic balance. And in some folks, the body likes to stay in an idle in the sympathetic side. So it becomes important to look at the adrenal glands and all the things that contribute to this. So here's a little bit better illustration of what happens when we're in pain. And it's broken down into what we call acute pain, transitional, and chronic pain. I think for this slide, acute pain, I think 3 months is a little bit long. I would say acute pain would probably be in the 1 month range, but this is still nonetheless a good illustration. So coming out of the gate, the person develops pain, and there typically isn't a lot of changes metabolically to accommodate this. But as time goes by, then what we will often see is that sympathetic dominance kicks in. And as that happens, we start to see fear of avoidance, we start to see changes in sleep, and classically we'll see that the tissues that have been traumatized actually atrophy and they get smaller. As we progress even longer, maybe towards the 3 to 6 months range, then we're going to see other things show up. We're going to see other medical issues. So because we're in a sympathetic dominance, now the person might develop things like hypertension. We're going to see changes in weight gain because, again, we're not moving the way we should. We're going to see maybe depression, addictions, because now we're taking painkillers. And we're going to see changes in sex drive and all of the other basic physiological functions. So chronic pain syndromes are more than just being in pain. They're a metabolic process that takes place and an adaptation that ultimately puts us in a position to where multiple systems in the body are out of control. Classically, pain is treated somewhere along this pathway. And I put this in because I think it's interesting to see the way that the pain pathway works. So pain is a perception that takes place from what's called a peripheral receptor. So this is our skin. When our skin is pricked, we have a trauma that is signaled to go into our spinal cord. Okay? And as it goes into our spinal cord, it gets into a part called the dorsal horn. And here there's a little relay station. And what happens is the spinal cord determines if it truly is a pain or maybe is it enough of a pain. So if we have a perception and the spinal cord thinks it's a significant pain, then it's going to pass that information on. But I want you to see this. It actually crosses over the spinal cord and it goes up to the brain through a tract called the spinothalamic tract to the opposite side of the brain. So when we feel pain, it can cross over. The interesting thing about this diagram is this. This area right here, called the dorsal horn, is probably one of the most important parts of the pain pathway. And in some people, this gateway is held open way too long or way too often, meaning that their perception of pain is heightened. And in this area is where a lot of the medications that we use to treat pain take place. Well, it just so happens that our body produces its own medications to keep this gateway closed, and that's what we call the descending modulation. So the brain is constantly communicating with the spinal cord to tell it that everything is okay. So it produces hormones and neurotransmitters to keep the spinal cord happy. One of the quickest ways to produce those hormones is through movement. And the more that we move, the more that this pathway or this gate stays closed. So local anesthetics are used to treat here along the pathway as well as here. And now we start to see the heavy hitters, the opioids and the alpha-2 agonists. These are the painkillers, the Percocets, and all of those types of things. So very interesting concept. Really the most important part takes place right here. Well, from a natural standpoint, what are some steps that we can take to pain reduction and ultimately the healing of the tissue? Well, the first thing that we have to do is preserve joint mobility. Again, like I said before, the health of the fascia is directly proportional to the amount of load or activity the fascia has to go through. So if we have limited motion at a joint, then the fascia is not going to be stretched or compressed normally, and ultimately it's going to shorten. We need to look at the upright posture, or the lack thereof, and our core stability. If we do not have good posture, then we're going to see a shortening of the fascia and an ultimate change of it. We may need to talk about how we can mobilize the fascia after it becomes fixated or stuck. Certainly we'll talk about reducing swelling and improving the blood flow. Well, can we take things that will minimize the inflammation, or are there other modalities that we can use? There definitely is, and we'll look at that. And then we'll look at feeding the connective tissue itself, the nutritional things that can be put into place to help the healing process. So the first thing I put in here is preserving joint mobility. The health of a muscle and the health of connective tissue is directly proportional to how much it moves. And if the joints in the spine, or the joints in our legs or arms don't move, then we get associated shortening of the connective tissue, including the fascia. So if we've lost mobility, the paramount thing to do here is to restore it. That is number one. Well, if we have good movement of our joints, we might just have shortening of the connective tissue. So stretching protocols become extremely important. Lengthening, for a lot of people, they just need to do lengthening movements. And for some, it just might be standing tall. A lot of people are just always hunched over. So how do we do that? Well, we maintain our upright posture and our core stability. This is a picture, a transected picture of a person's abdomen, and this is the core. And what I want you to see is these inward arrows. These inward arrows mean that the core's job is to work like a girdle, is to pull everything together. And when we lack core integrity, we can't do that. So then everything more or less starts to pouch outwards. Here is a side picture of that, and it talks about these little compartments that I referenced on the radio the other day. The top of the core is the diaphragm. The bottom of the core is the pelvic floor. The back portion of is the spinal column and a group of muscles called the multifidus. And the outside portions of it, or kind of the barrel part of it, is a muscle group called the transversus abdominis. So this is your core, and all of these structures work to keep everything inwards. When we do that, we maintain good integrity of the spinal column, we maintain good upward posture. In most cases, we maintain good mobility of the extremities and ultimately our fascia. So when we have changes in the soft tissue and we want to mobilize it, there's some things that work extremely well. One of the strategies that I give people as far as homework is using things like a foam roller, or there's these hand rollers that you can use. They're more or less a rolling pin for your body. And what they help do is they help to break up those adhesions or the tightness in the fascia. They help to mobilize the connective tissue that's there, and they help to restore the longitudinal capacity of those tissues. So as you work those out, then those tissues can open up. In some cases, we might want to target it a little bit more specifically, and this is when we would look to the people in the acupuncture department, something called dry needling. We put needles into the bellies of the muscle or in the connective tissue to break up the adhesions. As that happens, it increases blood flow, the lymphatic response. So not only does it improve the mobility, it also improves the healing process, which is essential too. If we want to reduce swelling or increase blood flow, a couple of things that I think are extremely valuable. One is something we call cupping. And cupping is more or less these suction cups that are placed on the skin. What they do is they pull the skin up, and by pulling it up, it's going to tent the fascia, it's going to tent the connective tissue, which is going to allow the fluid to drain out. It's also going to increase the immune response. And also, I like this. This is called kinesio and we've probably seen athletes with this on. The K-tape is similar to the cupping, that it pulls on the skin. It increases a tenting effect to allows drainage. It also increases the proprioception of the muscle. So the K-tape does a really good job at reducing inflammation and more or less re-educating the muscle on its role. From an anti-inflammatory standpoint, there's certain modalities that bring a lot of benefit to the healing process. We have older technology in the form of ultrasound, which I still like and use a lot. It's a sound wave that produces a heat that will break up adhesions, inflammation, and scar tissue, promotes the healing system. So it causes the cells to turn over and to regenerate faster. And conversely, on the flip side, there's newer technology called a cold laser. Exactly what it sounds like. It's a laser that produces light but no heat. And it too also reduces inflammation and improves the healing process. So when you want to change the quality of the tissue, you often need to do things to it to cause the immune system to recognize that there is a problem there. So ultrasound and cold laser will propagate the changes in the tissue and shift you more to quality connective tissue as opposed to more adhesions. Well, we would be remiss if we didn't have some nutritional things for our healing process. The first and foremost, the biggie is proper hydration. Just too many people do not have enough hydration and are chronically in a tightened or shortened state. So for the most part, if you take your body weight and you divide it by 2, that's a good place to start as far as ounces a day. So if a guy is 200 pounds, he should have about 100 ounces of water spread out over the course of the day. Most people do not even come close to this. There's certain electrolytes and vitamins that are essential for the health of our connective tissue and for muscle function. The B vitamins, specifically biotin, have a lot to do with the tensile strength. Electrolytes, potassium, calcium, magnesium, have to do with muscle contraction, relaxation, and very often people do not get enough magnesium or potassium, so they get a lot of rigidity in their muscles, and they get a lot of cramping, which causes the fascia to shorten. Manganese is another big player in the role of muscle physiology and connective tissue physiology, so I like to use that. Our ground substances and sulfur donors, we looked at that picture before of the connective tissue, and we saw that ground substance is kind of the batter in the background. Well, that's made up of all the things that donate sulfur: glucosamine sulfate, chondroitin sulfate, MSM. We can also take collagen as a standalone, and also we can take hyaluronic acid. If you're going to go this route, I think it's probably best to take a conglomerate of all those together, because there just seems to be more of a synergy and a better effect. And for some folks, anti-inflammatories in the form of herbs can be extremely effective, and also omega-3 fatty acids. Bromelain and papain on acute situation, meaning that right after we had an injury, can be very important in the healing process. As an injury becomes more chronic, the turmeric and curcumin, I like those a lot. And essential fatty acids, I think, are a no-brainer for almost everyone. Our diets are extremely omega-6 driven. We eat too much vegetable oils, not enough of the good omega-3 oils. So adding in some fish oils are great. One of the questions I get is what's the difference between the krill and the omega-3 from fish? Well, they're from 2 different sources. Krill is a small plankton, and the most omega-3s are from mackerel or sardines or smaller fatty fish. Some people seem to tolerate one more than the other, so I usually tell folks to start with omega-3 fatty acids from a conventional source like a sardine or a mackerel and see how they do, and if not, then they can switch to the krill form as well. About 2 grams a day it seems to be a good place to start. Some people need more, and you can measure that in blood if you so choose. Well, I hope we all learned a little bit more today, or at least certainly opened your eyes to the importance of the fascia For those of you that have more in-depth questions, feel free at any time to call me at the office or email me. I'd be more than happy to answer those questions for you. If your questions are a little bit deeper, there's things you don't want to discuss over the phone or email, you certainly can call and come in and sit with me. And as part of what we do at the Roselle Center, we work with a charity called Caring for Others that helps the homeless and needy get health care and other essential services. So for today, over the next 2 weeks, I'm allowing people to come in the office for a donation to the charity, $99 donation. Normally our exams are $225, and we can do a full workup and an assessment to see if we can help you with your ongoing health needs. So if you're interested in that, please feel free to call the office and they can get you in as soon as possible. The offer, unfortunately, because we're so busy, is over the next couple weeks. So if you're interested, please give us a call. And again, if you have any other questions, give me a call at the office and we can go from there. Thank you very much for your time, and we hope to see you soon.